Hi, everyone, and thank you for joining us at Slim and Grace Academy. I'm Danny Owens, FNP, and I have Richard Hernandez here. He's also a family nurse practitioner. He's joined us from South Carolina. So I want to say hi to everybody, Richard.
Hello.
All right, so we're going to be talking about hormone replacement therapy. So Slim and Grace Academy does offer some guidance on hormone replacement. Dr. Kevin Brown actually has made a comprehensive masterclass for hormone replacement, which is by far one of the best courses I've ever taken. I've done WorldLink, I've done Elite NP, I've done A4M, and mind you, those are great courses, but his really hones in on real world things, like what actually happens to patients when you give things, and talks about estrogen dominance and testosterone replacement in men and women, so things like that. So we're going to kind of dive into actually what hormone replacement is. Um, so I kind of want to start with, hormone replacement. When we think of testosterone and progesterone and estrogen, we picture muscly guys and things like that. And that's not what it really is. We're trying to restore hormones that we used to have, especially in any man or woman in the age of 30 and over. We need to restore the balance when we had it when we were in our 20s. So that's our goal for hormone replacement therapy. Whether it's menopause, whether it's androgenic effects with men. I mean, that's what we do. But so Richard, I'm going to give you the floor and just kind of let you ask some questions. So
Yeah, I just feel like it's a topic that isn't touched on as much as we'd like in school. And if you're coming from a normal nursing background, you probably don't get a lot of exposure to hormone replacement. Myself, coming back from the ER, there's not, I mean, we don't see that often, they come up. And, after I got out of school, seeing patients here and there, I've kind of relied on you a little bit to guide the way a bit. But some of the questions that popped into my head is right away when someone's asking about it is this safe? Is
right.
this something that I need to be worried about starting or not starting with my
Yeah.
patient? So one of my questions was, how do you go about that initial, first eye exam and kind of the first time you get your eyes on that patient, and what am I looking for?
Yeah. Okay. That's a very good question. So the question whether or not hormone replacement is safe is a very gray area. They are very much leaning towards safe. But we're looking, so when a patient comes in and the first thing you're going to really like hone in on if they even need hormone replacement is their symptoms. So they're, it's these women and men that are coming in like, I'm exhausted, especially around like midday. I can't sleep well. I have just some brain fog. My energy is just not there. That's kind of where you're leaning like, you're looking at their labs and, everything's kind of normal, like their CBC, their CMP, their B12, their vitamin D, everything's kind of on the normal side, even their thyroid, like it's normal. And it's like, I don't know what's nothing else is showing me why you're having these symptoms. So we turn to be like, you know what? Let's check your hormones. Um, Now, safe, that's going to be a hard question. It really depends on everybody individually. So genetics, whether they have a history of clots or strokes or breast cancer. And, FDA did remove the black box warning off of estradiol for breast cancer, but there's never a definitive thing saying this is 100% safe or it's not. So the main ones is really just like active or recent hormone driven cancers. So those are the ones we really have to watch out. And it's not necessarily a no, it's really just individualized on if, let's just say, they're like, well, my mom had breast cancer. Okay, well, how old was she? So if she was under 50 and had breast cancer, you really need to steer clear away from, especially like the oral versions of estrogen. The transdermal estrogen is kind of more on the safer side. Again, not 100%. And that's where like informed consent really comes in discussion, like really just honing in on like, this is the risk and this is the not. But transdermal estrogen is fairly safe for people with history like that. History of blood clots, strokes, uncontrolled cardiovascular disease is a big one, and then untreated sleep apnea in men for testosterone therapy. But another one is, so I know the liver disease for sure, but is history of blood clots. Let me see, stroke. Yeah, history of, and of course, men, prostate cancer. Now, that is not proven that prostate cancer and testosterone related, but does kind of show in the lab work that testosterone can raise that prostate, the PSA. There is no clear evidence that testosterone causes prostate cancer, but again, we don't know, so it's not
I
100%.
wonder if that's just because of the increased like sexual activity, you know,
Probably.
being able to perform there, that kind of increases that. One thing I was
Yeah.
going to touch on is just the other day I had, this is sort of related, but I had a patient show up, excruciating chest pain. She's probably mid 50s, history of blood clots when she was pregnant.
Okay.
But she had just gotten started on estradiol, just in the past 3 months or so.
Okay.
Anyways, we work her up and, ended up sending her to the ER. She had a heart attack in STEMI. So, initially, her EKG was fine. The only thing that made me worried was that she had a little bit of shortness of breath with that chest pain. And
Okay.
then I end up, following it. I should get to the ER. Her tropes were negative on arrival, and then right before they discharged her, it was positive, and then higher again. But my point being with that is, as a normal, nurse practitioner, I see that I get a little worried. But she had been started on it, and it was a known history of DVTs.
Hmm.
And not to scare anybody off on hormone replacement, but that part, I guess, scares you a little bit in the back of your head. But if it doesn't scare you, I think that's a whole other, that's probably even
Yeah,
scarier as a provider.
absolutely. If it doesn't scare you, then you shouldn't be doing it. So do you remember if she was on oral estradiol or if she was on like a patch or cream? Do you remember?
It was a cream. Yeah, it
Okay.
was a topical
Okay.
cream. Yeah.
So yeah, so the transdermal, I mean, like I said, some that's the more safe side. It's more
Hmm.
bioidentical, more customized, but still,
And I
it's
don't know if it's it doesn't mean, and it doesn't necessarily mean that it's related. It could be not related at
right.
all. But
You're right.
just that in the back of my head was the only thing that she had no other former cardio issues besides DVTs like 20 years prior.
Right.
So
And I always say
something
just
to,
because there's a correlation doesn't mean that there was a causation. So like just
yeah.
because it's correlated doesn't mean that that's what caused it. So
Hmm.
you are right. It could be like, I mean, she was pregnant, but pregnancy, look at the hormones. They jack up. So I mean,
Hmm.
maybe she has maybe some hormone driven cancer risk. So I mean,
Hmm.
that and it's hard because women need estradiol. Women need estrogen in their bodies. So it's like, what do? Just not give this woman, what she needs, and it could cause, bone brittle bones. So it's really hard. It's a hard one, but yeah, I mean that's a thing. But just because, like I said, just because they have that history doesn't mean to know. That just means slower titration, careful route administration, shared decision making. But that's where we don't rush the HRT. If we do that, we really have to go in small at a time. But yeah,
Interestingly enough, the cardiologist that saw her there did not take her off of it.
yeah,
And the note actually had noted that she needs it for, she had some other, I wish I had it now looking back, but she had some other condition that it helped a little bit with. So,
I know. So
um,
really, the what
yeah,
outweighs what the benefits outweigh the risks type of thing, and very
yeah.
careful monitoring. Yeah, you're right. Um, yeah, that's a hard one, but that's why patients are very leery because they get
Mm-hmm.
on TikTok and Google and they see all these. I got cancer from estrogen. Did you? I mean,
Mm-hmm.
real. I mean, you probably didn't, but what do, right? Okay, so do you have any other questions right now?
Yeah. So, your typical patient, 45-year-old male comes in, let's just say, I've ruled out, his sleep study, comes back, it's normal. Thyroid function's normal. Liver enzymes aren't, abnormal. There's no anemia going on, no depression, anxiety, or maybe there is, but, all those things I've kind of addressed. Now I'm looking at testosterone. When am I having this patient come back? What time should his labs be drawn? And then what intervals am I going to be having him repeated before I start him on testosterone?
Yeah, so that's very important. So you need to have at least two blood draws of testosterone, maybe even three. Um, that so with women, that's a big one too. So women 18 to 21 days of their cycle, so their first day of their period, you want to wait 18 to 21 days to check their hormones, unless they don't have periods anymore. Men, we like to at least have at least two testosterone levels to make sure that it's low because it changes. Ejaculation does cause, like, it can cause like fluctuations in that, especially the PSA. So at least two. So I would do at least two morning blood draws to make sure that they actually have low testosterone. And you also want to get their sex hormone binding globulin. So whether that's high or low will tell you if they're actually not producing testosterone from their testes or if there's something going on with the pituitary gland. So yeah, so you have to probably at least two. Three, I mean, some men are just like, I'm not going to go through the trouble, because it's like, it's a pain in the butt. A lot of men don't like to get their blood drawn, but if it's really weighing in on feeling better and changing their life, they're going to do it. But I would do at least two to make sure that they're actually low. Do that sex hormone binding globulin, do a full panel. I mean, always their CBC to make sure that their hemoglobin hematocrit stays in normal range, total and free testosterone, because the total testosterone is great, but that free testosterone is going to tell you what's in their body, what's roaming around freely that they can use. Sex hormone binding globulin, and then always an estradiol. You want to check their estradiol because men have that too. When they actually have low estradiol, that can affect their testosterone levels as well. When they're too high, adjustments can be made. We really steer clear away from like AIs, which is like the inhibitors. So like anastrozole, things like that. We try to steer clear of those because men need estrogen, and practitioners like to use those freely, and we just don't do it. We just make adjustments. But yeah, good question on that one. But definitely check it, and then check it again. Probably between 2 and 4 weeks later, just to kind of see where your fluctuations at. But yeah, that's what I would do.
Okay. And then, um, let's say I have a 22-year-old who shows up, 22-year-old with the same symptoms. Is that too early? Is there too late to start this? Can a 70-year-old, start on can an 80-year-old? When does it
Uh, in my honest opinion, I don't believe that there's never too late. What am I going to tell my 7-year-old male? Sorry, it's too late for you to feel better. It's too late for you to feel good. No way. So it's really, that the decision making, the history, to make sure that they're not crazy diabetic, whatever. If they're cleared, like you were saying, like no anemia, they're diabetes under control, no sleep apnea. I feel that
normal
there's no age limit.
EKG, things
Right,
are okay.
have at it. Just closer monitoring. Young, that's where it's really tricky. So if they're in their 20s and they have low testosterone, make sure you're doing the luteinizing hormone and the follicle stimulating hormone, so the FSH and the LH. That's what's telling you again, like what's going on. Is it their testicular? Are their testicles just not producing, or if it's something going on in their brain, like in their pituitary gland? So honestly, if they're in their 20s, I would be more comfortable with them seeing an endocrinologist, because it might be something a little bit deeper, because in their 20s they really shouldn't be having it. Have I seen them have low testosterone with nothing wrong with them? Yes. I have seen it where their testes are just not producing, and that could be a genetic thing. It could be an emotional thing. It could be it could be so many things. But in a primary care setting, it'd probably be best for an endocrinologist to go over that, because they'll probably get an MRI of the brain to make sure nothing is going on. But too late? I don't think so.
Okay.
Like I said, why would you tell them a 70-year-old that comes in here with nothing wrong with them? Nah. You know what I mean? Like, you're too old to feel good. Absolutely not.
Yeah.
So, yeah.
Now, there's I don't know if it's a misconception or not, but once you start replacement for testosterone, does your body stop, making it on its own? Or is that a gray area there?
It's a gray area. It's a yes and no. And I see practitioners using like HCG or Clomid to kind of help with that, especially in the younger years. But you really want to be careful with young and testosterone replacement because of that, because of infertility. So the question as, does your body stop producing it? Here's the science behind it. Whenever you're replacing testosterone, your body's like, oh, I don't have to anymore. He's giving it to me, so I don't have to work as hard. That's kind of what your body does. So everybody's different on that one. So on that one, I don't know. But you just have to really be careful with the younger generation, especially if they're still trying to have kids. So if you have a 28-year-old coming in and they want testosterone, great. But let them know it could cause infertility because it lowers their sperm count. And a semen analysis would be a good idea to get if that's the case. But Clomid and HCG is something that can help maybe keep their fertility better. But yeah, that's really, it's a hard one. But a lot of my men will come in and be like, I'm done having kids. So it's like, okay, well, great. Just so you know, let them know infertility is a thing. I mean, that's really a serious thing, and that's a lawsuit waiting to happen. Truly, if you don't tell them that and they don't end up having kids and they get infertile because of it, you got a lawsuit on your hands. So that'd be really, that's that informed decision making and consent forms, which is in that hormone replacement class I was talking about with Dr. Brown. He talks about that. He gives consent forms, protocols, especially with infertility. So it's really important. But yeah.
Okay. Well, I know we've been kind of hovering around testosterone this time, this entire time, but let's jump over to estrogen. So, is there any other misconceptions with estrogen, or I guess with testosterone, before we leave on that
Um,
you want to clear up before?
well, so no, I think we hit pretty much the good stuff on testosterone. There's so many things, and I'm just going to
Hmm.
throw it out there. Hormone replacement is very complex. I mean, there's so
Hmm.
many things. I've learned different things from different trainings. But no, so estrogen, and like I said, until I took Dr. Brown's class, I didn't even know that estrogen dominance was a thing. I mean, like estrogen dominance in women is huge. Like it makes them moody and just bloated and irritable. And I didn't even know that how important a balance was for that. So let's just say a woman comes in, okay? Let's say, because I had she was 32, 32-year-old female come in. Her estrogen was out the roof. I think it was in the 500s, which is pretty high. I think 120, 100 to 120 is kind of a good range. But just out the roof, and her progesterone was in the ground. And at the time, I'm like, oh, do I put her on an estrogen blocker? But no. What should have happened was she should have been put on progesterone. So when your estrogen's high like that, you put someone on progesterone, it kind of balances. And that's really what we're looking at with the testosterone, the estrogen, and the progesterone. It's a triad. Those three have to be in balance. And so, yeah, so let's talk about estrogen. So, estradiol deficiency and estradiol dominance. You really have to know the difference between those two because, what are you going to do? Now, let's just say I have a woman come in, her estrogen's low, progesterone's low, testosterone's low. Okay, she needs all three of these babies. Okay, you do not start all three of those at the same time. So let's just say we do. We say, you know what, I'm gonna give you a cream that has estrogen, progesterone, testosterone. Here you go. She comes in and says, Danny, I feel great. I feel so much better. Well, what made her feel better? Was it the estrogen? Was it the progesterone? Or was it testosterone? So even though it's a pain in the butt because you kind of have to do it once and then wait 3 months, do it again, wait 3 months, do it again. It's a process. But if we don't do that, we're not going to know what helped that woman. So we really have to find that balance. And I always tell my patients, Rome was not built in a day. So it's always going to be the same thing like with hormone replacement. That's why it's so important. Hormone replacement should really be its own niche. It should be its own thing because it's very complex. Um, but yeah, so estrogen, transdermal is always safe. Oral really it goes through the liver and then you don't get most of it anyways, and it's just a thing. But transdermal pellets, there's even troches that you can use. Those are the best alternatives, but everybody's different, so you really have to go and see what people want. Now, there are women that are like, Danny, I can't take a pill every day, or I can't take a troche every day. I don't want to put cream on. So we talk about pellets. So they're more sustainable. They jack that hormone up and give you that slow, steady release of hormones. But progesterone's huge. If I had to choose one hormone for a woman for the rest of her life, it'd be progesterone. It helps with breast health. There's really not that, and if there is a risk of breast cancer with progesterone, it's very, 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 very little, if at all. And I never say there's never a risk. I always tell my patients there's always a risk with everything. But progesterone is good for breast health. It's good for that balance of estrogen dominance. And honestly, women have more side effects and bad symptoms with the estrogen dominance than they do the deficiency. So, but yeah, it's a triad. It's a balance.
Hmm.
Yeah.
Well, I think it sounds like with most meds, that's kind of how you should go. Like blood pressure management. I'm not starting someone on the combo pill right off the bat. Probably if their blood pressure is otherwise not that bad, I'll start one at a time myself and then have them back. Now, when you start someone on this stuff, how often am I? You started them on it, initial med. What's the follow up process like, and what am I doing? What am I looking for,
Well,
ordering?
Usually it depends on what we're looking at. I like to do 3 months. So 3 months, I start them on estrogen. Let's do a 3 month follow up. That gives their body time to adjust. Now I have read 6 to 12 weeks, whatever, whatever. But I think 6 weeks is too soon. I feel that your body's just not, you're not giving enough time to adjust. So I would start them on estradiol, give it about 3 months, let them adjust, then come back and say, okay, how do you feel? Check their progesterone again, make sure, where we at. And then if the progesterone is still low, okay, let's give them that progesterone at night. 3 months, do it again. Testosterone is my last one. Now, women come in and it's mainly the libido because testosterone helps with mental clarity, helps with insomnia, helps with libido, but so does progesterone, so does estrogen. The libido is really the main one that testosterone really focuses on. So estrogen and progesterone for women is where we start. That's truly how I feel about it. But 3 months. So I would do 3 months, do your progesterone, wait 3 months, and just kind of say, and I tell them, pay attention. Pay attention to how you feel. Because I love these numbers on the sheet. I love looking at your lab numbers, but that's not all we're looking at. We need to treat how you feel. And if you don't feel good, we need to make some adjustments. But 3 months is my rule. So,
Okay.
yeah.
Is there one, for both estrogen and testosterone? Is there one, application that's best? Is it, IM? I've heard, or the orals, all the other different options. What's your go-to for both of them? What's
So
in
there's
your
so many
opinion?
factors to that. A lot of it is money. So a lot of people come in, especially my older women that are on Medicare and on a fixed income. We do typically go the oral route. I don't like to do that, but I do start with the estradiol zero point 0.5 milligram oral at night, see how they do on it. Then do the progesterone, 100 milligrams, the micronized progesterone, which actually is bioidentical, but I can send it through their pharmacy. That is usually what I do, not by choice, but by me, but mainly price. And in my area, we're a rural area, but there's really just not a lot of money here, which is fine. I mean, that's fine. But my go-to is cream. The reason I like cream is because I can put whatever I want in the cream and they can apply it. I like them to apply right here on the arm because it's a very thin area, and it's less, so if they put it on like the inner thigh or whatever, that can transfer to like their partner. Here, less, transferable. People like to do it on their arm. Again, if you pick up a grandchild, it can transfer right over to that kid, right? So I like to do the inner arm. But I like the cream. It's more subtle. It's not like a wham bam, here's your estrogen, because fluctuations in mood and headaches and those symptoms can come. And another important thing you need to tell your patients is you will expect changes. So you put them on estrogen, they might have some, maybe a little bit of headaches or some mood changes. That is to be expected. So a lot of my women will come back at their 3 month and be like, I stopped taking it. It gave me headaches. And I'm like, oh, like that is to be expected. Please let it will pass. Now, if it's extreme headaches or something extreme, and obviously we're going to stop it. But I tell them, expect changes. But I like the cream. So I like the cream the best. The trochees, I like trochees too, but people don't like trochees because they taste funny and they take forever to dissolve. So I think cream's the best. That's my go-to. Creams and trochees and pellets, and then orals the end. That's my very last choice. It usually depends on their budget. So, but yeah. hmm But I
I
like
know
that.
you in rural areas, and I'm over in a rural area too. There isn't a lot of like specialties to send these people to.
Right.
But let's say that you're working with someone and you just can't get things under control. Who am I referring this type of person to? And like,
Probably endocrinology, to be honest. I mean,
okay,
and unfortunately, we only have one endocrinologist here,
hmm
and they do like to hone in on hormones, but not as much as we do per se. And that kind of sounds crazy, but maybe like a naturopath. Here in Kingman, we don't have one, but like
hmm
Phoenix, Vegas, naturopaths really can hone in. They look at everything: the thyroid, the anemia, and I'm glad you mentioned the anemia. They
hmm
check all of that because it's a one big picture. Because if their thyroid's not in check, if their thyroid's out of whack, and you give them hormone replacement, I mean, you're just throwing it out the door. I mean, their
right.
thyroid has to be good before you do all this. So, naturopaths, if you can't hone in on it and you're just like, I can't figure it out, probably a naturopath or an endocrinologist. Yeah.
Yeah, well, that answers a lot of my, my fears
Mhm.
and thoughts. I mean, I'm sure that there's more out there on,
There
how
is,
to do
and
all
that's
this.
why,
But is there anything that you want the providers to know, that you wish that you
honestly,
knew early on?
what I wish I knew is, to talk about, good nutrition with these patients, good nutrition, strength training, sleep hygiene, and stress management. I mean, that all is a big, huge part in hormone replacement too. Like, this affects your hormones. Your sleep affects it. Um, how much caffeine you're taking in, how much, you know, bad food you're taking in. I mean, um, that all plays a role in this. So if you're not having, good sleep hygiene or a good diet, hormone replacement, yes, it'll help. I'm not gonna say it won't help, but those things like strength training, especially, that will help you so much if you have that core and then you add hormone replacement. I mean, life changing, life changing. So we always try to start with the basics. And I wish people knew that. I wish they knew like how important it is to do it, and it's hard. And I'll be there. Right? It's hard. It's hard to eat clean when there's a McDonald's every 15 feet. Or or Starbucks or whatever. So it's very hard with America right now. That's what I wish I knew. And communication matters. Dose adjustments matters. And symptoms are not bad. Symptoms are cues. They're cues to tell us there's something going on. There's something wrong, and that's why dosing adjustments are good and lab values are good and checking to make sure that these are, we make adjustments and things like that. So communication is very important. Um, I think that was, and like I said, Dr. Brown's class. I mean, he touches on all of that. I mean, he even gives not just some generic consent form. He gives you protocols. He gives you like in real world scenarios. Like he's seen it. He's done this for over 30 years. So he's seen it. He knows what can happen with this, and that. And he even had patients that ended up with breast cancer on hormone replacement. So he knows and he teaches about it. So it's really good. But when done responsibly, HRT is just one of the most rewarding things that you can do, truly, especially for your patients. But yeah, but I was one of the misconceptions is HRT causes cancer. It's really that's just a misconception. So yeah.
And where do I find that Dr. Brown's information at? What is that?
So Slim and Grace Academy, you can just Google Slim and Grace Academy, but it's academy.slimandgrace.com. You can go there, and right now we're doing $100 off of the course if you use the code HRT 100. And so it's $100 off his course. And I'm telling you, I've already had people take it, and I've had great, great, great response from it. So I'm very happy. Yeah. But
Awesome,
we're
cool.
gonna do podcasts like this more often. We'll kind of touch on more topics, and especially with you, Richard, if you have questions, this is where we're gonna answer them, and hopefully we can help other providers with those questions.
Well, thanks for having me on. I appreciate it.
Yes, thanks for joining, and we will do this again another time.